doing supine PCNL for the kidneys which are in ectopic position, and probably if you talk of a supine PCNL in ectopic kidney, probably that's the only position which you can do PCNL. There is no question of doing ectopic kidney which is situated in pelvic in a prone position. And we have been doing this PCNL. I'm going to show a quick video about the microperk which we perform in the supine position from the anterior abdominal wall. So this was 57 years old male, the complaints of pain in abdomen off and on. There was no other problem. And this was the ectopic kidney which was lying. You can see here that this was the kidney. This kidney was, the pelvis was facing anteriorly. But what is more important is that when we do ultrasound ourselves, this was the 1.7 centimeter stone. And when we see this ectopic kidney, we always first check the ultrasound ourselves in the outpatient department, and then we see whether we are going to get any window or not. And we got that window. This was the CT IVP, and you can see here the right side kidney was functioning properly. The left side kidney was actually crossing and was coming on the right side, and this was having the stone in the pelvis, which was 17 millimeter in size. So this was the ectopic kidney with stone in the renal pelvis, and we decided to do micro perk in this patient. As for any PCNL, the first step is to put a ureteric catheter, and this is very important step, that you give a little bit of a tilt and confirm again that how you are going to see the kidney. Is there any bowel or is there any organ between the skin surface and the kidney or not? And if there is none, that's a perfect case. Now here you can see that ultrasound guided puncture is made into the upper calyx. You get this into the lower calyx. You get the fluid, and then you can see here that the contrast is injected from the needle. As you know, microperk is just a needle which you have to puncture. There is no question of putting a wire. There is no question of putting a dilator or anything. Once you puncture it, you just have to take out the inner sheath and put a telescope, and you are inside the kidney and your job starts. So this is how we gave the tilt position, and this is how we started the micro PCNL in the ectopic kidney. This is the vision you get. And the stone was very clearly seen through the lower calyx approach, which was very easily seen on ultrasonography. The stone is broken completely with the ultrasound. Nowadays, we have so many high power and the thulium laser and Moses and so many advancement in the laser technology. You can powder the stone or dust the stone completely by whatever settings you are putting. Microperk, the disadvantage is that stone fragment cannot be retrieved. But here, the important thing is that the whole stone was dusted out. The fluid irrigation was under pressure, and the ureteric catheter, which we put in the micro PCNL, is of a end multiple hole, and it keeps on draining the fluid outside into the fluid which is coming in the ureter. So this way we can see the whole pelvis and the stone completely cleared up. This is how the fluid from the pelvic cholesterol system keeps on draining. And once we confirm on fluoroscopy and endovision that the whole stone is completely cleared, dusted out, this is just a puncture mark you can see. So this is the supine PCNL for the pelvic ectopic kidney with the anterior approach. Most of the times we take the posterior approach for the normal position kidney, but this is the anterior approach, and this was the post-operative X-ray. You can see that the stent was kept through the urethral route, and the was completely cleared. So this was the first post-operative day. 1 month later, complete clearance, and patient was discharged in 24 hours. Well, total ectopic kidney, whether it is microperk, whether it is a conventional PCNL, mini PCNL, we have hardly any complications. Only two we had to convert to the laparoscopy or open surgery. Otherwise, no major complications of bleeding and fever. And the stone-free rate, if you see, that is a significant stone-free rate. Some fragments which are there completely washed out either with the observation or with the auxiliary procedure. and we could achieve in this series almost a 98% stone clearance, which is done in the supine position. So that's it about the supine position, not for the normal kidney, but for the ectopic kidney. So that is what I wanted to present.